want to start off by saying, on behalf of Dixon Center for Military and Veteran Services, we are excited about partnering with Consensus Health once again in shining a spotlight on the challenges that veterans and their families face in finding and receiving quality health care. And I'm also excited, again, I have the opportunity to moderate our first panel today, and you're seeing some of our panel members now starting to join us. And very shortly, I'll introduce them. They are a group of practitioners, thought leaders, researchers who every day are examining how to bring better care to those in marginalized communities, including our veterans. Again, I'm Colonel Sam Whitehurst. I'm the Vice President of Programs and Services at Dixon Center for Military and Veteran Services. But before I do go into introductions and allow them a chance to make their opening remarks, I would like to set the stage for today's discussion for our very first panel. And as part of this, I'm drawing upon a recent report called Stand To 2021, Advancing Veteran Employment, Education, and Health and Well-Being, that was published this past February by the George W. Bush Institute and the Institute for Veterans and Military Families at Syracuse University. After looking at that, I think I have found that some of the observations in the report really should give all of us pause, and also highlight the urgency of ensuring that veterans and their families have access to quality health care. From the report, for example, they make note that veterans who receive their health care from the VA, and as many of you know, only about half of the 19 million, almost 19 million veterans that are in our country do receive their health care from the VA. But those who do receive it from the VA, for those that live in rural communities, it can often be very challenging, very difficult, just because of the geographical distances involved. And then for those veterans who do receive their health care from private providers or from community providers, they sometimes face obstacles due to a lack of understanding of military culture and other contextual issues. Women veterans in the report that they have challenges accessing gender-specific services. And post 9/11 women veterans were significantly more likely to say that they are not prepared to successfully navigate the healthcare and benefit system. And specific to mental health, negative beliefs and stigma associated with mental health still makes veterans reluctant to seek treatment. One of the things I found, I guess, most alarming about the report is that over half of the respondents to the Stand To survey who reported a mental health problem, half of those did not seek care. And veterans, as also noted, veterans have unique healthcare needs that often require coordination of care across multiple chronic conditions. During today's discussion, what I hope is that we're going to tackle some of those issues, some of those statistics that I just went through, but we're also going to try to answer and address the following questions. How do veterans access their health care? I think there is a perception that all veterans receive their health care from the VA. And as many of you know, that's not exactly true. Again, about half of our 19 million veterans get their health care from the VA. Others seek it from private and community providers. And unfortunately, their sole source of health care is either coming from urgent care centers or emergency rooms. What are the specific challenges that veterans face in accessing quality health care? How do these challenges impact different veteran populations? Women veterans, veterans of color, rural veterans, and veterans on the edge of poverty. And are there challenges, are there lessons learned from how we approach how veterans access health care? Are there challenges and lessons learned that we can also apply in the non-veteran population? Now, I want to introduce our panel. So today we're going to be joined by Carrie Farmer, who's the co-director of the Rand Epstein Family Veterans Policy Research Institute and director of Rand Healthcare Quality Measurement and Improvement. We're also joined by Dr. Maggie Allard, founder and CEO of Community Health Design Institute. We're being joined by Nathan Lutke, a healthcare administrator and public health leader. And we're being joined by two colleagues from the Meadows Mental Health Policy Institute, Sean Hanna, who's the Senior Director of Veteran Initiatives, and Tempest Sherrill, Senior Director for Strategy and Innovation. Now, as we kick things off, I'm going to go to each of our panel members and ask them to tell us a little bit more about themselves and also about the work they are doing supporting veterans and their families. And Carrie, I'll kick it over to you and let you start us off.
Great, thank you so much. Thank you for that introduction. So as Sam said, my name is Carrie Farmer. I am a senior policy researcher at the RAND Corporation. For those of you who aren't familiar with RAND, RAND is a nonprofit, nonpartisan research organization. I've been at RAND for 12 years. My research focuses on improving access to high quality healthcare for veterans and service members. I've studied issues around how veterans access care from VA and from community providers, the quality of care provided by both VA and community providers, and barriers that veterans experience accessing healthcare. I'm also the co-director of our new Veterans Policy Research Institute. Our mission of the Institute is to conduct evidence-based research to improve the lives of those who served in the U.S. military. I'm really grateful to be here today, and I'm really looking forward to this discussion.
Great, thanks, Carrie. And let's go to Dr. Maggie Allard from the Community Health Design Institute.
Hi, everyone. It's such a pleasure to be here. Sam, thank you for inviting me onto this panel. First of all, just a heartfelt thank you to the men and women who serve and have served in our armed forces. Your sacrifice and dedication to this country is not forgotten and is greatly appreciated. So I recently started the Community Health Design Institute truly because of the severe lack of healthcare access throughout the country, not only for veterans, but for a variety of populations, much worse in rural areas, but also in high density urban areas. So we at CHDI seek to advance innovative healthcare teams, including community health workers and a newly burgeoning field of community paramedics, who can bring care directly to the home and the community and even to the homeless wherever they are. As well, we seek to equip these innovative care team members with the technology to communicate with the larger health and social service network remotely from the field where they're practicing. Also to do remote documentation, to be able to order referrals for social services from the field, and to be able to monitor patients remotely. So we feel that equipping innovative healthcare providers with this type of technology really advances care in vulnerable populations who need access. Thank you.
No, thanks, Maggie. And let's go over to Nathan.
Good morning, Nathan Lukey. So I spent the last 15 years working in both public health and healthcare administration with focus on serving rural areas and underserved populations, and really focusing on those areas where our at-risk populations intersect, including veterans in the rural areas, which is a large percentage of our veterans actually live in those rural areas. And so assuring that we're meeting them at that intersection, having shared experiences, pulling them into any of the prevention efforts, and also assuring that high-level services are provided wherever they may be.
No, thanks, Nathan. And now we're going to go over to our panel member who's going above and beyond the call of duty today. I guarantee you he's not physically driving right now. He is stopped. So, Sean Hanna from the Meadows Mental Health Policy Institute, who's traveling, but great to have him here as part of the panel today. Over to you, Sean.
Yeah, great. Thanks, Sam. I appreciate it. Yeah, so Sean Hanna, Senior Director of Veteran Initiatives, as part of the policy implementation team at the Meadows Mental Health Policy Institute. Some of my background is a Navy corpsman, served with the Marines in the 90s. Federal government sent me on a nice little vacation to Somalia in '95, so got to see a little bit of stuff there. Subsequent to my service, I got out in 2000. I studied traditional Chinese medicine. I'm a licensed acupuncturist. I'm not practicing anymore because as I was standing up a complementary and alternative medicine program for veterans and their families, I met the Samaritan Center in Austin, and they brought me and my team in to integrate what we were doing with complementary and alternative medicine with their mental health program, their clinical mental health program called Hope for Heroes. And from there, I got involved in peer support, both at the VA and at the community level. There was a small state initiative that Texas was putting out that eventually I worked with the Department of State Health Services and all of our local mental health authorities across the state to implement the Military Veteran Peer Network. So 37 coordinators across the state tasked with recruiting, training, supporting, and rewarding veterans and their families in support of other veterans and their families. So outside of the offices, in the field, community-based peer support. Subsequent to that, I became the director of veteran mental health at the Texas Veterans Commission, where I oversaw that state program. And then about 6 years ago, came over to the Meadows Mental Health Policy Institute to take the relationships that I built and the experience that I had and help the Institute build out its technical assistance to community-based programs across the state. So now I have the pleasure of working with the leading organizations, community-based organizations across the state in helping to meet the needs of veterans and their families outside of VA, but then integrating with VA. So I really look forward to this conversation and bringing what I can and mostly learning.
No, thanks, Sean. And now let's go over to one of Sean's colleagues at the Meadows Mental Health Policy Institute, Tempa Sherrill. Tempa, over to you.
Thank you so much, Sam. It's an honor to be here. And a little bit of my background, I actually connected with Sean a few years ago in the community space. I am a licensed professional counselor, and I've been in the mental health nonprofit community service space for the last 10 years. It all started with my experience as the spouse of a veteran, Marine and Army veteran. He served in Afghanistan 2008 to 2009, and we were a reservist family. So his day job was police officer. And I really connected with Colonel Sutherland's story of when he came back, and that piece of the tears in his wife's eyes as he when they were in the car. And that was it for me. Like, the nuances are so complex for families and the experiences, and so that fueled my passion to go back to school. I was actually in education at the time, teaching high school, and I had a fire lit inside of me. I went back to school, got my master's in counseling and psychology, and said, I want to make a difference. I want to do something for the families who are experiencing these life-changing things as a result of this war. And so the impact on our family helped me understand it on a level that a lot of other practitioners don't understand. So I set out to developed 2 programs for veterans, and eventually also for first responders, and around trauma and the effects and impacts of trauma on the veterans and their families. I founded a nonprofit and a program called Stay the Course, and that's where Sean and I met in that space. And I've just recently come over to Meadows, the Institute, and am joining the work and efforts on a more statewide, global level. So I'm here to speak from that lens, and I'm really happy to be a part of this conversation and to hear from all of you.
Thanks, Tempa. So I'm going to go ahead and jump right in. I think is probably the overarching question that we are addressing today. But just before I do that, I do think it's important that when we talk about veterans, we really think in terms of who veterans are. Because in my experience, working in the veteran space, that there's this perception that when you think of a veteran, you think they're male, white, and older. That is kind of the common perception of what it means to be a veteran. But I think it's interesting if you look at, especially our post 9/11 generation, if you look at that generation, you really get a feel for the uniqueness of veterans' health needs, as well as the diversity that's actually resident in our veteran population. For example, 30% of post 9/11 veterans are women, which is double of what it was during the Vietnam service era. The male post 9/11 population is more diverse than other service areas, with almost double the number of non-white veterans, 20%, and more than double the Hispanic veterans, 11.5%. And the female post 9/11 population is even more diverse than that, with 32% non-white and 13% Hispanic veterans. And about 75% of post 9/11 veterans are below age 44, with a median age of 33, while veterans from other service eras are mostly above age 55. Unfortunately, that's the category that I'm in. So I think it's important to understand, to give that context as we have this discussion, is kind of this monolithic view that many people have of veterans. When you start to break it down, it's just not true. It is a very diverse, veterans as a whole are incredibly diverse, and as well, they have unique health needs, which sometimes can be challenges and obstacles in making sure they can access healthcare. So here's the question. With that in mind, with that as the backdrop, what are some of the challenges accessing healthcare that you have seen in your work that veterans face? Not only our post 9/11 generation, as I just went through, but also really veterans from all eras. And Carrie, if you could start us off, and then from there, I'll go to Maggie, then we'll start to go around the panel again.
Sure. So, Sam, as you referenced earlier, I think there's this common misperception that all veterans get their care from VA. Really, it's not only do not all veterans get their care from VA, but not all veterans are even eligible to get their care from VA. So of the 19 million veterans, 9 million veterans are enrolled in VA healthcare, and in a given year, 6 million veterans receive care from VA. So the rest of the veteran population is getting their care from other sources. And even among veterans who are getting care from VA, they're not getting all of their care from VA on average. So many veterans not only have access to VA healthcare, but they also have healthcare through their employer, or they may also have TRICARE, or they may, for older veterans, also have Medicare. So they're getting care from a variety of sources. So I think when we think about veterans healthcare, of course, VA is a huge consideration, and we pay a lot of attention to VA healthcare. But we also need to think about all of these non-VA healthcare sources and what are the barriers that veterans may face from those sources. One of which you referenced is, and that Colonel Sutherland referenced too, is sort of understanding military experience and being military culturally competent, and being able to understand the unique healthcare needs of veterans, understand the available resources, even asking, are you a veteran, to all patients, to really even have, a provider is not going to know necessarily that the patient sitting in front of them is a veteran. So even initiating that conversation. But one other thing I want to throw out there is that it's not just accessing care. So just getting in the door and having a visit is not sufficient. It has to be high quality care. There are lots of poor care out there, and really making sure that we are setting up structures so that veterans are accessing high quality care, that providers are providing high quality care, and that we really ensure that that it's not just getting to the appointment, it's just that they're getting the care that they actually need.
Thanks, Carrie. And Maggie, let's go over to you.
Okay, I just wanted to give a little bit of background. I don't know if I did that during the introduction. So I've been a physician and internist in underinvested communities for about 25 years. The majority of my work with veterans has been at a VA during training, but also veterans of lower socioeconomic strata as a medical director for complex populations over the years. So I think there's really three things with access. One is difficulty accessing healthcare resources. Secondly, there's a difficulty transitioning into the civilian population. And then finally, it's social determinants. So I'm going to be saying a lot of the same things that Carrie has just said from a slightly different perspective. So as far as difficulty accessing healthcare resources, not all VAs are created equal. So if you're in a big hub city like Denver or Boston or Cleveland, you're going to have a robust set of resources for employment, for job opportunities, that kind of social determinants care, for housing and housing insecure patients. You're going to have behavioral health resources and PTSD counselors who are trauma informed, and you're going to have a variety of types of specialists. But if you're in rural areas, this is often not accessible. And this is worse for female veterans and for minority veterans, especially in rural areas. Then the second thing is that there is a real difficulty transitioning into the civilian population. I have seen this in my post-release patients who were recently incarcerated or incarcerated for many years. I've seen this in refugee patients. So in those various populations and also in my military veterans, where it's sometimes it can take 1 to 2 years, and there's this kind of confusion, there's anxiety, there's depression that just comes from the transition itself, and that takes a while to get over. With veterans, whether or not they have PTSD or significant mental health issues, I see a hypervigilance and an alertness, which is part of their training, and actually it is not a pathology, it's just part of who they are. There's also a stoicness. So sometimes there's a reticence to inform me about physical health issues, much less mental health issues. And so because veterans may advocate less than my other patient populations, they may get less care. And the VA is often a really good midpoint for care because it still has a lot of military culture. There's a lot of structure. You only get a certain number of appointments. Things are very regimented. But I think it's very different when you come to physicians who are trained in the Western health system, where we're supposed to ask open-ended, touchy-feely questions like, how are you doing? And we're supposed to engage patients in this back and forth dialogue and set care goals together. And so sometimes initially, especially after being on tour, it may be difficult to access that kind of care. Finally, there are, with civilian care, care can be in different buildings within the same city or in different cities altogether. So geographically, even for my non-veteran patients, it's very difficult sometimes to access all the pieces of care. And then as far as social determinants go, housing insecurity often comes from two things. It can come from mental illness and or substance use. In my veteran population, I've seen more, the substance is usually more alcohol. And when you have folks who are housing insecure or homeless, it is more difficult for them to access care. Simply for everything from transportation to getting medications stolen or not being able to get reminders when there are visits. There are so many barriers to getting to a clinic, to getting to a pharmacy, to sticking to a care plan. And social determinants very much affects that.
Thanks, Maggie. I have that are some great points, and I'm interested in kind of following up on a couple of these. But I want to let's go over to Nathan, because I know you definitely have a perspective, especially on some of the challenges in our rural communities that Maggie highlighted there. So Nathan, over to you for your comments.
Sure. First, I'd like to pull it to the bigger picture. I mean, if we consider any of our own personal experiences, utilization of healthcare is complex. It's complex if you've got great healthcare, know what you're doing, are working, have privatized healthcare, have access, all of those things. It's still complex. It's difficult. So when we layer upon that a second option, so a VA option, which is essentially a social medicine model, which may simplify some pieces, but lacks the flexibility. It's low in cost, may even have incentives for you. And then you have this other option that is entirely different, functions differently, essentially a fee-for-service option. The private option gives you that level of flexibility. You might be looking for some specialization that you couldn't see otherwise, and even just the option of choice, but may impact your pocketbook a bit more to go that route. Every clinical medical decision you're making is balancing these two different systems that, quite honestly, people working in them sometimes have a hard time understanding, right? So I think the access issue can be as simple as the complexity and, you know, our general response to something that evokes fear, anxiety, it's overwhelming, is avoidance, right? And that's compounding a risk factor that already exists for veterans. So when you look at, you know, an older veteran who's going there and did everything they could through community care to make sure it was set up so it would be billed properly, that this would be handled correctly, that all gets missed. Simple registration error somewhere in the process. The default is going to be a Medicare billing. That Medicare billing then causes a further down the line issue for VA, who doesn't do partial reimbursement. So just a quick example of how something as simple as, I thought I had it all set up. I went in there, I took care of everything. I had my I's dotted, T's crossed, walked into this alternative site for care, and now the billing is another obstacle for me. All of those lends itself to avoidance or apprehension for that next time you go to seek care. And, you know, when we consider the rural options, I mean, we have a number of risk factors there, of course. The rural population in general can be characterized as having, there's going to be more of a lack of trust or concern when it comes to engaging with government, with large institutions. So again, pulling back and not necessarily jumping in when you think that perhaps I need to seek care, whether that is mental health or anything else. So I think that that first step of making it easy for a veteran, for anybody to engage, is all overlaid an already complex system that we don't do great. So I guess that would be my first and foremost concern when it comes to access for veterans.
Nathan, while you were talking, I was smiling a little bit because I could have sworn that maybe you have like a camera over my shoulder for my last 2 years since my retirement, because I went from, in my time in the military, a very simple system. And I don't think a lot of people understand when it comes to healthcare in the military, it's a somewhat very easy to navigate. If I had an issue, I just go on sick call, or I go down to the troop medical clinic, which is on every installation. A lot of our installations have hospitals on them, fully staffed hospitals, and go to that or into local community. It was just very easy. You have a problem, you just go, and the problem gets resolved. And then, you know, fast forward, once I retired, I entered that very complex system you talked about, and it can be incredibly frustrating. And when you talked about how the reaction is avoidance, I was just like, yeah, that has described some of my interactions with the civilian healthcare system. And so I understand that frustration and those challenges very acutely. So no, thank you for that. Okay, let's go over to Sean for his thoughts about some of the challenges veterans have accessing healthcare.
Sure. And, you know, within the Institute, we talk a lot that mental health care is healthcare. It's all healthcare. And we have it siloed off in our society, in our systems, like mental health is over there somewhere, where we know that 80% of depression can be treated in primary care. It's not screened for universally. And so then it's not treated. If you don't ask, you don't know, right? So like anyone who goes into the doctor, doesn't matter what you're going in for, they're going to take your vital signs on the way in through the door. Now, if you're coming into the doctor and you've got knee pain and they take your vital signs and your blood pressure is 210/160, they're not going to be talking to you about your knee today. that's now become a cardiac event, and because it's a life-threatening condition that you just walked in with, they're going to go to that. Your knee is getting put behind you. And we could do the same things in primary care if we had universal screening of mental health conditions, just a PHQ-9, something. Every time a patient comes in, screening for mental health concerns universally, then we could identify them. But why don't we do that, right? Because everything has to have a bill code. Everything has, because it's just the way our system is set up. That now you're encumbering, you're taking more nurses' time, more screening time, more doctor time for something that their practice really isn't set up for. So it's taking universal system change. It's going to take all of us to make a difference in this. Now, the VA, to their credit, does universal screening in primary care. Like every time I go to the VA, they're asking me about my sleep, they're asking about my drinking, they're asking about my stress. Like all of these things are universally screening. And if I screen positive on any of that, they've got a specialist that's coming to talk to me right there to do further screening to see if this is something in order that I'd be willing to go to treat. And my cohort, my peers, we all experience that when we go to VA. But I'm one of those people that doesn't go to VA except maybe once a year. I use my private insurance and get treated out in the community because the VA is not convenient to where I live. It's not that I don't appreciate their care, it's just the time, right? When I can schedule a doctor wherever I want, whenever I want, but I go in and I'm not getting culturally competent care. Whatever my chief complaint is, they're asking me about. And there are some days that would probably be beneficial if they did do more of the how you feeling, how you doing. In fact, you notice I'm on the road. There's an initiative that we're working on as it relates to children. The Institute has worked with our government leaders and the leaders of our state medical schools to implement a program called the Child Psychiatry Access Network. I'm literally going into pediatric offices and letting them know about this no-cost network that they can be a part of, where they can get consultation in primary care from the lead psychiatrist, lead child psychologist, and psychiatrist at the medical school to get children universally screened and right to get these things treated early. But it's an evolution of a system that is slow. And when I go into these doctors' offices that we've been calling, we've sent them materials, they're not enrolling. They found it into, they're not enrolling. I go, they're busy. They're dealing with COVID. They're dealing with sick kids and all kinds. Like they're just super busy, and it becomes something else that they need to do that we're adding on to their plate. So we've got to figure out how to do this, where mental health care is just health care and it's universal with the rest of it.
No, that I think that is a great reinforcing comment to Carrie's, talking about how the lack of a kind of military cultural competence among providers. And that's a great example, Sean, that you provided about the idea of universal screening, something that happens as a matter of routine. Well, not only in the VA, but also in military health facilities. That happens as a matter of routine. But that's, as you pointed out, that does not happen as a matter of routine or happen at all as you go into maybe a private provider or a community health or a provider there in the local community. That's a great point. So Sean, or I'm sorry, Tempa, let's go over to you.
Thank you. And yes, to echo what many of the other panelists have already said about the complexity of the larger global system, I'd like to just reiterate that. And the need for universal screening, the need for the connection of mind and body and the treatment of the whole person. And back to Colonel Sutherland's comment about the approach of wellness rather than pathology. And if we can look at the whole person and treat the whole person, you know, studies have already shown what that looks like, and it's successful. Multidisciplinary teams are successful in the trials and research that's been done. So through my experience in working in the community nonprofit space, what I've seen over the last 10 years is veteran after veteran after veteran bringing in their reason for seeking out help in the community is because of the hoops they have to jump through, the you know, all of those steps and the roadblocks that they run into of getting the help they need, and they give up. You know, that window of opportunity gets closed. And so that's why the grassroots organizations and movements across the US are successful, is because we're filling that gap. You know, there are a lot of organizations and companies who are trying to think outside the box, which is why we're here today. So waiting lists, the overwhelmed system, the fact that families aren't served nor are they identified. So along the lines of the universal screening, you know, for mental health in general, we aren't screening to identify the veterans and the veteran families, the children of veterans in schools. You know, that is cultural competence. And back to what Dr. Sutherland said, the general population doesn't know who we are. Well, no, they don't. They don't know where, and these families exist all over in every community in America.
Yes, thanks, Tempa, and also I think it's important, as you just did, you kind of, you know, we're not just talking about veterans here. We're talking about their families. We're talking about the children of veterans, and making sure that they have access as well. And they have unique challenges, especially the children of veterans. I know this is an area that there's been a lot more discussion about in recent years, about some of the unique, especially mental health challenges that the children of veterans have as well. So I think it's important to bring out. You know, I thought it was interesting. Nathan talked about the complexity of the healthcare system and the challenges with navigating that. And then Sean talked about, in terms of providers, kind of, you know, not being in tune to the needs of veterans and their families, and also understanding what is available to support them. And I'm taking a very long way to get to Carrie, because I know Carrie was involved in a study focused on New York State, and I think if I'm right, Carrie, that was one of your observations or conclusions, was this idea that a lot of our providers, there's an education component for veterans that they need to understand to navigate the healthcare system. But there's also this education or training component that providers need to embrace as well, so they understand. Like Sean's out there right now trying to educate providers on a particular program, but you found in the report in New York State that many providers just are not in tune to some of the programs that are available to support veterans and their families.
Yeah, that's right. In that study, we applied a definition of readiness to treat veterans, and that encompassed understanding military cultural competence, or having taken some sort of military cultural training, providing evidence-based medicine, asking about patients are veterans, and a number of other factors. And 2% of all providers met the readiness criteria. So that's a very, very small proportion of providers that we could comfortably say this is a provider that, you know, we would be sending veterans to, that is providing the kind of care we are expecting. So there's a lot of work to do, and there are a lot of challenges. I've been thinking a lot about VA community care, and so as several of you have noted, VA has a lot of processes in place in VA facilities related to training, and training around suicide prevention, and training around screening. And VA community care providers, and even beyond, that's sort of one subset of providers, but even and then beyond that, providers who aren't involved with VA whatsoever, there's no requirement for that kind of training. And VA and other organizations like Psych Farmer make a lot of trainings available in terms of understanding veterans. I mean, Psych Farmer has a 15-minute training, which is great, which is a really good basis. And even if all providers could take the 15 minutes to watch this video on 15 things veterans wish you knew about them, that would go a long way to even starting to think about this, but there's no mechanism to make that happen. Providers have to want to do it themselves. There's no incentive to do it. So I think that's one of the big challenges, is how do you change provider behavior to improve their ability to provide quality care to veterans.
Just a quick follow-up to that. Do you think there, in terms of incentivizing provider behavior, I don't know if things like the Mission Act, you know, the push, I guess it's been what, 2 years now since they started implementing the Mission Act, where it was going to increase the ability for veterans to go outside the VA system to get community care. What are your thoughts about that, Carrie, in terms of, is that a way to incentivize provider behavior, the opportunity to participate in that program?
No, because the contracts with providers don't require it. So it's not, when VA was setting up the contracts, it was, you know, something that I think VA was interested in, but the managed care companies were not interested in. Their concern was about attracting providers to the program. So if you put more requirements on providers to join the community care network, the fewer providers there will be interested in participating. And so unfortunately, that's those types of requirements are things that are not in the contract. So it has to be, you know, sort of from a policy perspective, that contract could be revisited. There could be modifications to require that. But I think there also has to be education of providers to try to, you know, if it's something that can't be required, it should be desirable in some way to either from a patriotism perspective, really providing the best care possible. I really think that providers may feel more comfortable treating veterans if they had some understanding about veterans. So I think that it's a lot of things. And Sean, I'm interested in sort of from your perspective of trying to convince these pediatric practices to join a resource. I think there might be similar barriers there of here's something that could help you, but it does require some work on your part.
I'll tell you, Carrie, because it's fresh right now. Yesterday, I was doing these same visits, and there's one that really stands out to me. I was talking to the office manager, and they have 4 pediatricians there, and she's like, "What is this about?" I explained the program and how it works, and it's a resource, and this is to help y'all better identify children with mental health issues, and then treat them here. And she's like, "Yeah, they're not going to do that." And I was, "But you could." She looks at it, and, you know, it's just me. We're talking. She's like, "They're not going to. Like, they're not going to treat it here." And I go, "Well, you don't have to, but somebody needs to. Like, somebody needs to treat these kids. And if it's not in your will, it's great. Screen them and let's get them somewhere else, because they'll also help navigate them to a third. What payers do they have? What insurance? Are they Medicaid, Medicare, whatever? You know, like, help them navigate to get to it. But they're in your office. Well, at least ask them, are they doing okay? Is there anything? And then let somebody else take it. And this is where I was like super excited for the past years to work with the IVMF on their Texas Serves initiative, part of their America Serves, using the Unite Us platform to tie together providers in the geography, where we talk about educating providers and having them better understand veterans or better understand particular ethnic groups or whatever the cultural experiences are. But I think we have to be reasonable in our expectations of how many different cultural trainings and population trainings. Like, when this person's real job is to be a subject matter expert on medicine, what do the labs say? What do the tests say? What's the diagnosis? What's the best treatment? What are we getting our outcomes? That there are other ways to approach it rather than everyone having to be an expert on everything. So it's like when we look at resource navigation across the social determinants of health, like Dr. Allard was talking about, you have Combined Arms is an example in Texas of resource coordination. I know Easter Seals and their has their I can't remember. I believe Colonel Sutherland mentioned it, but Easter Seals has their coordinated, you know, in communities. Their organization, United Way, is doing it. The IVMF and their America Serves, so that the idea is any provider, do what you're best at, do what you do, what you're funded to do. Try and identify, while you got the person, they have other needs, and then get them to a community organizing third party that does that resource navigation, rather than every organization having to try and know every other organization and all their programs. Like, they just can't. To make that direct referral, we have the technology and we have the ability to have resource coordination done in communities where now we could just screen. I do what I do. I'm doing housing. I screen for other things. There's other needs. I give it to that third party to navigate those things. Those solutions exist, and I think are going to be critical for us moving forward and beyond the veteran population, like for other populations as well.
Let's go to Maggie.
So, I mean, so many comments on what was just said, but I think, you know, I'm going to date myself a little here, but looking at the domestic violence movement that was in the 80s, and then there was disparities that started in the late 90s, early 2000s, and then we went into human trafficking, which was around 2010 forward, and then a bigger push into cultural competence, and now we have a lot of different things on the table. But with each of these, the way it got into medical school education, the way it became an essential training for physicians for continuing education, is by speaking to the overarching bodies. So it would be potentially, and we can talk out offline on how to strategize about this, but the medical school governing bodies and the American Medical Association, the American College of Physicians, governing bodies have to get involved so that this becomes an essential training. So that's one piece. And of course, that's state by state. Some states mandate things a lot more, like where I've practiced in Massachusetts, there is a variety of trainings we have to do. So it just has to be mandated in that way. Regarding screenings, you're absolutely right. There are certain payers, there are certain ACOs that require mental health screenings, and there are others that don't. So we're really talking about this moment in our country where we really need to have healthcare and social service integration. And there needs to be just a set of screenings across the board. Healthcare is no longer, you know, biological care, it's biopsychosocial, and we need to really embrace that model and bring everyone to the table. A big part of that is technology, EMR integration, communication platforms, bringing communication together. So the panelists are correct. The time is now, and we have the resources to do this. We just have to do it smart and do it together.
No, thanks, Maggie and Sean and Carrie. That was a great conversation. I wanted to go over to Nathan, and I know that we talk a lot about. I think a lot of our conversation we talk about accessing healthcare is a very kind of reactive. You know, it's all about reacting. Someone has something that's wrong with them, then they go and have it addressed or try to have it addressed. But an important component of healthcare is also the preventive side, of the more proactive side. So I know you've been involved in some of this work in trying to come up with preventive strategies when it comes to healthcare. So, you know, if you could make some comments about that, and then if there's any parallels to veterans and their families, if you could bring those out as well.
Sure. So, you know, I'm thinking about this. I think I want to start by framing the question a little bit. So when we talk about, you know, community-based or preventive strategies, depending on the context that you're discussing it in, it's going to mean very different things, which we don't do ourselves any, you know, we don't help ourselves at all with this issue. But if we're talking about clinically and we're talking prevention, oftentimes that right quickly goes to screening, immunizations, preventive medicines, behavioral counseling, weight management, those sorts of things, which are all important preventative measures that we take on the clinical side, but are only truly a community-based in the same sense that, for example, the VA refers to what we would think of as a local clinic as their community-based outpatient clinic, or the CBOC. In that sense, yes, it provides better access. You have primary care usually closer to you, but that is the limitation of those preventative strategies. And it's going to be up to the screenings we're just talking about to track somebody in the proper direction. You know, VA has done a great job of addressing, you know, key social determinants issues, getting down to, you know, improving the physical activity, how somebody can better use their built environment, dietary needs, what kind of personal practices improve and educate you on those things. Those are all things that might be an intersection. But when we're starting to get public health and we're talking about preventive strategies, it's all around the social determinants of health, right? So it's primarily around your socioeconomic status, your education, your built environment, health access, those sorts of things. And so when I step back and think, what's really interesting after listening to Colonel Sutherland discuss what it means to interact and engage the veteran community is we lack an interface in so many places in order to accomplish that. There's so much great work out there that lacks this interface. So for example, if I'm looking at physical activity, because that's something that can be encouraged, maybe even a program or a gym or something like that as a connection when you raise concerns about weight management or something to your primary care doctor. But in public health, what that looks like is, I'll give a quick example of initiative called Complete Streets. So it's been around for 15, 20 years. It's been around for a long time. It actually has been coming up in a lot of federal policy and discussion around infrastructure. And what it is making sure that our neighborhood streets are safe for biking, walking, cars, public transportation, everything, so that we have a community we can get out and interact with. So it not only increases your physical activity, but your social engagement. All great policies, all great practices, and when we're able to put them in place, have the potential to impact a veteran and their family as well, because they may very well find that they've been prescribed the, get out and walk, get in nature, take a step out of your front door, try to combat some of these isolation tendencies that you've developed since you've returned. And having a community that is built to support that creates that advantage. However, unless there's a specific means of engaging a community, cultural competency across the board, right? Whether it's a minority community, veteran community, rural community, you can't build it and they will come. So I think that some of the others on this panel probably could get better into examples of specific community-based programs that do exist that draw that connection. I think Tampa talking about how we are the network that fills that gap is really spot on, because in general, even our best placed policies aren't necessarily going to impact veterans as directly as they potentially could. Now we take that to the rural environment as well, where that impacts them entirely different, right? So that same example I give you of Complete Streets, well, in a small community, maybe they're already a bit more safe, but the truth is they're a lot more sparse. So they're difficult to have that same physical activity, because yeah, it's green from here 5 miles into town, but it's all 55-mile-an-hour road. So if you're a veteran living 5 miles out of town and those are your options, getting off of your front porch still can be a challenge. So we need to find ways to interface, I think, to make a community-based option that much more of an advantage for our veterans and other underserved communities.
Tempo, your thoughts on that? I just want to follow up in terms of that idea of kind of coming up with those community-based options or solutions.
Absolutely, thank you. Yes, Nathan, I completely agree, and that's what I have observed and heard over the last 10 years, and have been involved in lots of organizations who, veterans need to be connected to their community. They need to be doing something. They need to be doing things that give them purpose. And that is incumbent upon the community to interact and engage. And with that concept that you said, Nathan, you build it and they will come, not necessarily. We have to reach across, you know, and interface that somehow. So getting them doing something outdoors, or, you know, there are a multitude of things, and at the core of that is peer support, right? They're getting support from maybe like-minded individuals or civilians even, and bridging that gap between the military world and the civilian world. So I believe that building connections, and Colonel Sutherland spoke to this, is one of the main keys to prevention. That's the bridge. Instead of looking at pathology first, the best prevention is to create these opportunities for connection and getting veterans and their families doing something and finding purpose.
No, that's a great point, and I just, you know, something that I share with as many people as I can when I'm given the opportunity is that I don't think a lot of people understand that when someone transitions out of the military, the loss of camaraderie and the loss of those strong bonds that have been developed in the military. I won't say that's unique to the military. There's probably other areas in our life where you can develop those strong bonds and that sense of camaraderie, but I can't find, I've yet to find kind of a better example that I've seen in my own personal experience in the military. Being around a small military unit, whether Army, Marines, Navy, Air Force, whatever it is, being around a small unit and seeing those young men and women interact with each other, I mean, you can just sense kind of that togetherness, the strong bonds and camaraderie. And that's one of those things that once you leave the military, in many ways that disappears. And that's a huge gulf that has to be filled. And I think we've all been touching upon this, but here we're talking about accessing healthcare, but we're really talking about overall wellness of veterans and their families and creating positive outcomes. And I think being able to do that, not only is it good to overall wellness, but I think is a good preventive strategy when it comes to how you manage your healthcare as well. Or it's a good preventive strategy to negative outcomes that could potentially come up when we talk about healthcare. So I appreciate you for bringing that up, Tempa, and Nathan as well. That was very good. I want to go back, if we could, Maggie, go back to you, because I want to talk about healthcare deserts, because I know you've done a lot of work in this. You mentioned it in your, I think you mentioned it in your opening statement, because I think there's this perception when we talk about healthcare deserts, everyone immediately goes to these rural communities. Nathan was talking about, you're in a rural community, you may live 5 miles out of town, it's a very sparse population to begin with, so there's not a lot of either providers or facilities there to support not only veterans, but to support other folks that are in those rural communities. But I know you've done some work where, those healthcare deserts actually can be in metropolitan and in urban areas as well, because it's not just geographical distance that creates a healthcare desert. There's these other factors as well. So I wanted to give you a chance to talk a little bit about that.
Sure. In high density urban areas, we see healthcare deserts as well. We see food deserts, and we see, high crime. There are a lot of things we see in high density areas. But for example, I've worked in Denver and the Bronx and in Roxbury and Lowell in Massachusetts. And in all of those areas, when I was at a federally qualified health center, we had a lack of nurses, doctors, behavioral health professionals at various times during my time there. And those are in very dense areas. It's just because the number of hundreds of thousands and millions of people who live in those areas have very complex needs. Again, biopsychosocial, and one primary care physician, one nurse, one social worker, one social service agency is not enough to bridge all the gaps. So you will see healthcare deserts in those areas as well.
I'm going to go back a little bit because I meant to bring this up when we were having the discussion about some of the resources. So I'll work with our partners there in Consensus Health, and we'll look at figuring a way to identify. When we're talking about, I think when we're talking about Psych Armor, and some of the trainings available. I think Carrie brought that up. That really cued my memory that there are a lot of great resources out there. So we're going to figure a way to put this and get this out to the attendees, some of the resources like Psych Armor and some of the others that have been mentioned as well, getting those out there so people know what's out there. So we'll figure a way to do that. What I'd like to do is, just talk about resources that are available out there, is just, if we could just kind of go around the horn. And if there are some certain resources, or not only resources, but if there's certain reports or studies that you think are important to this conversation, give everyone a chance to address or to speak to some of those. And I'll start with Carrie, if that's okay.
Sure. So I, not to totally toot my own horn, but we have a number of reports related to veteran healthcare available on through our Institute website, which is veterans.rand.org. We have a couple of reports which I think are really useful. They're dense, so I'm warning the audience about VA healthcare. So really understanding the healthcare needs, the unique healthcare needs of veterans compared to non-veterans, as well as the healthcare that VA provides and what the evidence really shows about access and quality of care. So one of those reports is definitely outdated at this point. It was in 2015, but the information about, if you want to understand who's eligible for VA healthcare, what kind of care is provided by VA, where are VA facilities located, that helps to paint the picture of what's part of this map and network and available resources for veterans. And I'm happy, Sam, to share with you some links that the audience might be interested in, as well as the report that you mentioned, understanding the readiness of providers to treat veterans, and what some resources may be.
No, yeah, that'd be great, Carrie. We'll figure a way to get those links out to the audience. And I don't think, after looking at something, I don't think they're necessarily outdated, because it's interesting. Even going back to 2015, you'll see some things going, yeah, that's still a problem. That's still a challenge.
I'll tell you one thing that I think is outdated from that report, which is the report on access and quality of care. There's half of, I'd say, the access piece may be outdated, and that's because that report was a congressionally mandated study after the big crisis that prompted the passage of the Veterans Choice Act in 2014. And so at that time, there were big news articles and a big outcry about veterans waiting for a long time for care, being on waiting lists and dying while they're on the waiting list, like really the huge scandal that caused the secretary to resign. And so since then, VA has made a very concerted effort to improve monitoring of access and opening more appointments in the community as a way to free up additional appointments. So I think the access issue has likely changed. There hasn't been a comprehensive study of it since then either. So the extent to which it's changed, I'm not totally sure. On the quality front, I think that is not outdated. The study after study shows that VA provides very high quality care, and that is at least as good and in many cases better than non-VA care. But to Maggie's earlier point, there's a variety of VA facilities, and quality of care is uneven across those facilities. So I think that's another thing that has not changed, and thinking specifically about VA care, sort of making sure that all VA facilities are providing the same standard of care is an ongoing challenge.
Thanks, Carrie. And Sean, let's go over to you in terms of, if there's any resources or tools that, and I know that you mentioned some organizations there in Texas that are very helpful. If there's anything else you wanted to highlight?
Yeah, I think I would want to highlight the ETS sponsorship program that is relatively new. It's a joint VA, DoD, and private partnership program. The period of highest risk for suicide in veterans 18 to 34 years old is the first year that they got out. It's the deadly gap, right? And just like you talked about, Sam, where, you know, it was easy to engage in healthcare when you're on active duty. You just go down to the battalion aid station, you see a corpsman, right, or an army, you see a medic, they do what they do, they send us the doc, like it's just right there, it's embedded. And so what this is doing is they're training sponsors across the country. It's part of Soldier for Life TAP. So anywhere in the world, a soldier getting out, they're piloting with the Army first, a soldier getting out, they'll see if you're going to one of these 6 cities or 10 or however many they have now, you can have a sponsor. A year to 6 months out, have a sponsor, a live human being that you can be talking to that can tell you about the community, the neighborhood, the schools. In the same way, if you have a sponsor when you PCS from one base to another on active duty, it's creating that transition. And they've been doing it for about 6 years in New York City. So soldiers from Fort Drum going to New York City, one of the 7 boroughs, could get a sponsor. They also have the technology in place so the sponsors aren't overwhelmed trying to be case managers. Technology's in place. They can identify the need, put it in the system, and get them navigating the system. So I think that's a really important program that is happening now between the VA, the DoD, and local organizations to implement as a resource to fill that deadly gap. And then just any opportunities that we have with primary care. We're going to be doing a pilot over the next couple of years in the Central Texas area, the Austin area, with a primary care, civilian-based community primary care organization, identifying their highest population clinic where veterans and their families may be going, and working with them to do universal screening. Did you ever serve in the military? Did a family member ever serve in the military? And if they say yes, here's a brief mental health screening to see if there's anything, and then using community organizations to make that referral, right? Get consent, get that referral, and then have someone else help that family member or veteran find the resource that they need because they know the communities, rather than waiting for the doctors or the case managers or social workers to try and know everything, right? So we're going to be piloting that. I think that it's everything that's been talked about are the resources.
And Tempa, did you have anything else you wanted to add in terms of resources or tools?
I do want to, on the mental health side, as far as a national nonprofit effort with the Cohen Veteran Network, they're multi-state, culturally competent provider of services to veterans and families and active military as well. They serve veterans of mostly all eras, I believe. And more and more nonprofits are opening up to all eras and not just post 9/11. But that's, a very good one. And there are multiple organizations like Cohen in Texas as well. And then as far as military cultural training, cultural competence, Psych Armor is amazing. I've utilized Psych Armor with new staff members over the years. But SAMHSA actually and the VA have great resources if you dig, into their resources that are available to anyone. SAMHSA has a whole section of, standards and cultural competence training suggestions on their site. So, if you look hard enough, you can find what you need if you really want to find it.
No, Tempa, you're right about the VA. Lots of information on the website. I don't know if I would call it the easiest to navigate. You could spend, like I said, there's a lot of information. You could spend a couple of days working through that, but no, you're exactly right. And Nathan, what about you?
So I think first I'd actually reference back to that RAND report regarding physician readiness to treat our veterans. And the reason I start there is I think there's an enormous conversation that's not being had, and that report uniquely highlights that. Having been somebody who I worked intensely with providers and physician relationships for many years, and I have a number of physicians who were trained, grew up in the military. Their first surgical experiences were, in Iraq and Afghanistan, who are profoundly impacted by it. But to Sean's point, when they go to care for a patient, it's not part of that dialogue. They are thinking, this is what I have to do to get this person well, here's the steps we'll take. So I think, the obstacle is the incentivization likely won't happen through contracts. It's taken time just to get quality measures built into contracts, and that's probably the right priority. So I do think, though, that some simple dialogue and awareness that report offers would be, like, if for those that are attending that are healthcare related, health insurance related, any of those things, I think there's opportunity there. From the rural perspective, I would say let's not forget about a resource right in front of us in most rural communities, which is our veteran services officers. They're a clearinghouse of information. They connect and make you aware of all these not-for-profits that might be around you, of possible interfaces, communities you can connect with. Something that goes beyond a VFW post, which is another common role. And that's not talking bad about a VFW post. They do a lot of things right? It's the sense of community that, and probably a starting point for so much of the work. It just incorporates alcohol, which is one of the things we're trying to battle at the same time. So I think those local resources that you can find in every county, a veteran services officer, can be a starting point for that interface I was discussing.
No, thanks, Nathan. Thanks for highlighting veteran service officers, because I think you're spot on. You're exactly right. That is a tremendous resource that I think sometimes is underutilized. So, and Maggie, over to you.
Okay, so I think, I'm talking more about frontlines clinical practices. So when looking at that, I think it really is recruitment and retention in rural areas, in urban areas, as well as building out the infrastructure. That would be the primary thing. But secondarily is using these more unique healthcare workers to go directly to where the patients are. So I've had quite a bit of experience with community health workers. They do everything. They're very culturally competent. They can be trained across cultures, and they do a lot in terms of education, care plan adherence, advocacy, accompaniment, or just giving someone companionship, and helping with case management and care coordination so that they make their appointments. When they're integrated well into an EMR, I will get alerts from them that a patient is missing a medication or needs a housing voucher form signed, so it becomes extremely seamless. So community health workers have been very helpful to me with veterans and all of my populations. Very similarly, community paramedics, which most rural counties have some type of EMT paramedic network associated with fire. So if those EMTs and paramedics can be trained in community paramedicine, they become an invaluable tool that can be deployed into any situation, whether urban or rural, and they go there. And what's really impressive about community paramedics is their level of clinical acumen. They're very much like a medic, right? So they have a lot of clinical training. It can be overlaid with cultural competency and other parts of the community paramedicine training. And they also have diagnostic devices and medications right on their truck. It's full of tools. And so if they have the appropriate medical control, if they have a hospitalist or a really good family medicine doctor who's rural, who does everything from surgery to OB, or an ED doc, then they can really do a lot in the home for chronic disease management, post-hospitalization transitional care, for acute care. They can do prevention, they can do social determinants, but a lot of that has to, the barriers include regulatory. It includes finding the appropriate medical control, having CPT codes so these things can be billed. I mean, there are still lots of steps to take before we're there, but certification and training is really on its way for this type of medicine to take place. Now, when you take community health workers then and community paramedics and you wrap them in the technology to communicate with a team, including infectious disease, alcohol recovery coach, behavioral health, primary care, then I have had synchronous and asynchronous conversations with an entire team where everyone is on the same page within a minute on extraordinarily complex patients. I've had community health workers find patients under bridges in tents and bring them in to appointments, to surgical appointments, to behavioral health appointments, and alcohol counseling or substance use counseling, veteran and non-veteran. These tools are almost in all of our hands. We need to move these types of things forward on the front line.
Thanks, Maggie. And I just wanted to go back because there's a point that Tempa made I want to make sure I highlighted, and that was Cohen Veterans Network. I can speak to the quality of the service they provide veterans and their families, because I have family members who are involved with Cohen Veterans Network, and we're very open and transparent about it here in the Whitehurst family when it comes to emotional and mental health. So I can tell you that is a resource that is really spot on in supporting veterans and their families. And I'm glad, Maggie, made the point about paramedics and EMTs, kind of looking at, when we talk about providers, again, we have this mental model of what a provider is. And I think part of increasing access is breaking that mental model and looking at, paramedics, EMTs, community health personnel, those in the community. I think that's a great resource to start to take a look at. So, well, this has been a great conversation. We're coming to the end, just a few minutes. Heather Flannery from Consensus Health will be giving some remarks, and we're all looking forward to that. But before we leave, I do want to give a chance to everyone to make any brief closing comments, and also give you the opportunity, if you would like, because Maggie brought this up to me yesterday, and I was kind of kicking myself for not thinking about this, but as we all know, we've seen recent events in Afghanistan, and there will be impacts to that among our veteran population. That may be one of the reasons I kind of forgot about it, because I'll be honest, for the last 3 weeks or so, I've really kind of put myself in a bubble trying to, we've talked about avoidance. I've been trying to avoid news about Afghanistan because I know for me it's going to be a process of reconciling my service in Afghanistan to where we're at right now when it comes to Afghanistan. And I am concerned about how that will impact other veterans, their families, and also the families, of course, the families of our fallen. So I want to give everyone a chance to make any closing comments or remarks. And if you would like to make any, share your observations or anything in terms of kind of recent events in Afghanistan and how that may impact veteran health down the road. And I think I'll work backwards this time from the beginning, and I'll start with Tempa.
Thanks, Sam. It's just been an honor to be a part of this conversation, and it's so refreshing and confirming to hear so many similar things being said, and thought leaders across the country. We don't know each other, and we've come together, and we're all along the same lines, thinking in the same direction. And so I'm hoping those interfaces can happen, and that we can continue the conversation and take action. We need a call to action around these solutions. And from our family, concerning the recent events in Afghanistan, just like Colonel Sutherland said, there are no two veterans the same, no two military or veteran families the same. The perspectives on what has happened are also just as different. There are going to be unique perspectives on this issue, and to be open and empathic in how we interact with others, and don't be afraid to talk about it. But I think listening and letting people be heard and to feel what they feel and grieve this loss, as it's a time of grief for a lot of people, to reconcile their service, and all of those things matter.
Thank you, Tempa. Sean?
Yeah, Sam, I just want to thank you and Colonel Sutherland and the Dixon Center for continuing to lead in this space, convening subject matter experts, driving the conversation forward. This has been really rewarding for me to participate in this. I've learned a lot and look forward to moving all this forward with y'all.
No, great. Thanks, Sean. And get back on the road so you can get more providers to get involved in the program. So thank you. Okay, let's go over to Nathan.
Yeah, so thank you for including me. This has been great, and I hope it's of value for all those that are participating. So I think I would echo part of what Tempa had to say. Like I'm probably the panel member who is least engaged specifically with veterans and more around the periphery on this. And so it required a certain amount of education and interest on my part to dig in. And the work that the VA is doing around what they referred to as evidence synthesis. So identifying alternative care, such as acupuncture, yoga, meditation, mindfulness, and where the evidence supports providing this care so that a primary care physician can connect and be confident that they're actually prescribing something that they're not comfortable with, hasn't been in their forefront in the past. I think that's honestly, that's when we look at like what all of you are doing, what the VA is doing, that's brilliant work. That is work that will set us ahead light years for years to come. It's an enormous undertaking, but I think it's great work. So I just want to echo the idea that we're doing the right work. Regarding Afghanistan, my first thought is for those that were, immediately looking for reconciliation or validation of their service. It's too bad we all don't have a Colonel Sutherland in our pocket, because he certainly could make you feel like you knew why you were there. And just remind everybody of all of those little events that each of those individual veterans experienced, and where the value was in those will be their reward. And think big, think personally around that. And there's no doubt that when we, take on something with very broad, enormous objectives, that the detail of that work can get lost. But don't lose it on yourself, because you were an important detail of that work all along, regardless of the outcome.
No, thank you, Nathan. Very well said. Maggie?
Yes, thank you so much for asking this question. It reminds me of New York City. I was there during 9/11, and afterwards there was just a spike in mental health issues for 6 months to a year, and then it started to level off a little. My husband's family is extensively military, so I have some secondary knowledge, and of course with family members and talking to them. And they span from the World War I generation, who really, there are very few with us anymore, all the way to present day. And I would say that, when you've dedicated your life to a mission and you have settled memories that you've worked out, whether or not you have PTSD, even if you don't have PTSD, and that mission was around freedom and democracy and honor and country, and even just taking orders and doing them well, and then that meaning is removed. It is not going to be unusual to see a spike in anxiety, depression, and even kind of a secondary, a remote form of PTSD, because you're reinterpreting memories, you're reinterpreting meaning, and for a lot of people, this is their life work. I have veterans who see me who may have only done a tour or served for a certain period of time, but they tell me stories every time they come to see me. And those are some of my most cherished memories, is hearing their stories, whether heartfelt stories or harrowing stories. It's things that I hold close, because that is the honor of being a physician, is being in the room with people in their most joyful and their most vulnerable state. Just as always, hats off to the veterans. Thank you for your service. And it was a real honor to be on this panel. Thank you.
Yeah, thank you, Maggie. And then Carrie, you can close us out.
Thank you so much, Sam, for for inviting me to participate in this panel, and thank you to the rest of the panelists. I too have learned a lot, and this has been a really wonderful experience. I'm grateful to be part of it. I guess one thing I take away that I really echo what Tempa said is that, and it also echoes what Colonel Sutherland said, is that veterans' experiences are very varied. And I think there is a tendency in the national discourse to have this idea of a broken veteran. And I think when we see imagery, and in fact, when we're looking for stock photos of veterans, it's often a veteran with his or her head in their hands, really looking down, like downtrodden, and that doesn't represent all veterans at all. And there are a lot of veterans who have had successful transitions. In fact, most veterans have successful transitions and have fulfilling lives. And I think we pay a lot of attention necessarily to those veterans who have more difficult transitions and more and need mental health care and other types of health care. But I think we have to also keep in mind, again, that there are a lot of different types of experiences and a lot of different paths post-service, and a lot of different experiences and feelings, and sort of thinking about that holistically, I think, is really important as we come out of these wars.
No, thanks, Carrie. I've run past my time, and so I know Sean is jumping in here right now, but I want to thank all of you for a really great and enlightening discussion and conversation. I really appreciate it. All of you guys have been great, and thank you very much for what you're doing to support veterans and their families, or really anyone who has any association with military. Really appreciate it. Thank you very much.
Thank you.